Hello, good afternoon. So, in our last class, we have seen the first part of anti-arrhythmic drugs. We have seen in detail about the normal physiology and what are the various mechanisms of generation of arrhythmia. So, from today onwards, we will see what are the drugs which can be given to control arrhythmia. So, among the anti-arrhythmic drugs, as you have seen before, I told you that we have a classification where it's called as the Vaughan-Williams classification of antiarrhythmic drugs. So, according to this classification, the drugs have been classified based upon their major mechanism of action, the major channel which is inhibited by them. So, we have class 1, 2, 3, 4, and 5. Now, in today's class, we'll see only the class 1 drugs, which are the sodium channel blockers. And these sodium channel blockers are further subdivided into subclasses 1A, 1B, and 1C because there is a minor difference in their mechanisms, and we'll see what are the differences. Now, before actually proceeding to the classes, I'll tell you a brief overview about how the antiarrhythmic drugs actually act on the heart and control the heart rate. So, these are the four mechanisms. Firstly, the decreasing of the phase 4 slope. So as you can see in this picture, the black curve here is the action potential generated in the myocardium. So what happens here? Here is the one action potential, and right now you shift to the red color, and this is the second action potential. Therefore, phase 0, 1, 2, 3, and phase 4. The antiarrhythmic drugs can suppress this phase 4 and prevent the excitation. Right. So as you can see in the red line, this phase 4 slope is going upwards, so it is permitting the entry of sodium. Sodium entry will occur, there will be excitation and there will be generation of action potential. So this excitation or the slope of the phase 4 will be suppressed by the antiarrhythmics. The slope will be flattened, and because of this, you see a flat line, and then the second action potential will be generated a little bit later. The first one comes here, but the second is coming here. So that is one mechanism. Coming to the second mechanism, so what you see here, after this first action potential, move to the red color graph here. The phase 4 is converting to phase 0 at this point because this flat red line is the threshold potential. Threshold potential means how much amount of stimulus is required to excite a particular cell. So the antiarrhythmic drugs can raise the threshold potential to this level, this blue line here. So whatever current the stimulus is given earlier will not be sufficient enough to excite the cell. So the action potential cannot be generated. So as a result, a higher amount of stimulus is required to generate an action potential. So this is another mechanism to delay the generation of action potential and thereby to decrease the heart rate. So coming to the third mechanism, by increasing the maximum diastolic potential. You see here the first action potential from the phase 2 to phase 3, the phase 3 graph is coming down, and here itself it is flattening and moving into phase 4, and then a second action potential is coming here. So the antiarrhythmic drugs can further lower this phase 3 and depress the level of phase 4. This is means the antiarrhythmic drugs are trying their level best to suppress this phase 3 curve and move it to the more negative potential. So what happens here is that when the next action potential has to develop, it requires some amount of time to move the baseline potential from this more negative to the higher level. So obviously, when you're starting phase 4 at this level, it requires a less amount of energy and time. But if you're suppressing the phase 4 to a much lower level, it will require more amount of energy and time. So this is third mechanism of delaying action potentials and thereby reducing heart rate. Lastly, most simplest one, increasing the duration of action potential. So if you see the red color line is first here, the distance between the phase 0 and phase 3 is this much, and here also is this much same. So after giving the drug, the duration of phase 2 will be prolonged, and phase 3 will come much later date. So you can see that the distance between this phase 0 and phase 3 will increase. So this is the action potential duration. The duration of action potential is increased, so thereby the generation, it will take some time to generate the next action potential. So by increasing the action potential duration, you can decrease the generation of impulses. So thereby decrease heart rate. So I hope you understood. There are four mechanisms by which broadly all the anti-arrhythmic drugs act: either decreasing the phase 4 slope, increasing the threshold, suppressing the maximum diastolic potential, and by increasing the action potential duration. So now coming to today's topic in detail, we'll see only the class 1 drugs, that is the sodium channel blockers. So before moving on to the drugs, let me remind you once again about the morphology of the sodium channels, which are located in the ventricular cells and also the atrial cell, by the way. So all these sodium channels occur in three stages. This is the open state, where they allow the entry of sodium into. And here, before entering the open state, comes the closed state, C for closed. So you can see this gate is closed here. Here it is open, so it was allowing the entry of sodium. When the gate is closed, sodium entry is blocked. The gate opens, sodium entry is allowed. And after some point of time, the inside gate is called the inactivation gate, will be closed, and sodium entry is blocked here. So even though this gate is open, the inside inactivation gate is closed here. So this gate will not allow the entry of sodium. This is called as inactive phase, or also called as resting phase. Now once the sodium channel enters the inactive phase, it requires some amount of time to recall the channel from the inactive phase to the closed state. And only in the closed state you can give some stimulus to convert it to open state. As long as the sodium channel is in the inactive state, there is no drug or no amount of stimulus can open the inactive state of sodium channel. Now, most of the drugs in the sodium channel blockers act only in the inactive stage. As a matter of fact, if you remember the chapter of local anesthetics, lignocaine, it acts by prolonging the duration of action and the duration of inactive state of sodium channels. That is why it will inhibit the transmission of sodium impulses. And similar is the mechanism of phenytoin, an anti-epileptic drug, that will inhibit the conversion of inactive state of sodium channels to its closed state. So let's move to the next slide. Now, one thing you need to understand that when the drug binds to this, this anti-arrhythmic drug binds to this inactive state of sodium channel, it requires certain amount of time to dissociate. And as long as the sodium channel is in the open state, it will allow plenty of time to attach. So what I mean to say here is that the drug binds to sodium channel in its open state and will convert it into the inactive state. Now the new molecule cannot bind to the inactive or the closed state. So when the sodium channel moves into the open state, again it will allow more time for the drug to bind to it and convert it into the inactive state. So that's what it seems here. At each diastolic interval, the drugs will dissociate and the blocker is released. So when the diastole occurs, when the sodium channels are moving from the inactive state to the closed state, that will allow the dissociation of the drug and will permit the attachment of new drug molecules. Now, why is it important for us to know? Like, see, this is the normal heart rate. Okay, there is some duration between these two action potentials. So the black line of phase 0 is when the sodium channels are open, and the sodium channels will get closed in the phase 1 and phase 2 onwards. So I was saying that during phase 0, the channel will be open, sodium enters inside it, and during this phase 1, 2, and 3, the sodium channels will be inactivated. It is during this time the drugs will get ample time to get dissociated. So again, during this period, some time is given for the by the channels for the drugs to bind. Now the heart rate is increased, and the action products are coming together. Here, time is not given by the sodium channels for the drugs to act. So as a result, sodium channel will be continuously increasing. The moral of the story is that basically all these sodium channel blockers can decrease the heart rate when the heart rate is increased, but they do not have the ability to lower the normal heart rate. So basically, a high heart rate can be brought down to a normal level, but this anti-arrhythmic drugs, especially the sodium channel blockers, cannot lower a normal heart rate to the lower side. It cannot convert a normal heart rate to bradycardia. Only tachycardia can be brought down to normal heart rate. So that much you can understand. Let's move on to in detail about each and every class of drug. For the class 1A drug, we have quinidine, diisopyramide, propanamide. So these come under the class 1A drugs. I suppose quinine or quinidine might remind you of anti-malarial drug. Yes, quinine was the first anti-malarial drug discovered, and it was also found that quinine has the ability to lower the heart rate. It prolongs the QT interval in ECG. So a different variant of quinine has been synthesized. It's called as quinidine, which has action only in the heart and does not have any anti-malarial action. So what does class 1A drugs do? They have two mechanisms. Firstly, they depress the slope of the phase 0 depolarization. So normally those sodium channels will open fast, they allow rapid influx of sodium. So you see such a steep depolarization phase. So when you give class 1A drug, the depolarization will occur at a slower rate. The slope is suppressed. And second mechanism what they exert is that they also increase the action potential duration. Now you need not get confused into these two diagrams. These are not two different diagrams, but one. What I mean to say is that these two mechanisms are exerted in the same action potential. But I've drawn two curves here so that you can understand. Class 1A drugs have two mechanisms. First, they depress the phase 0, phase of depolarization, and second, they will prolong the action potential duration. That much you need to remember. Like here you can understand properly. This gray color shaded part is the normal action potential. So when I give a sodium channel blocker, the slope is depressed and the duration of action potential also prolonged. So normally this much was the duration. Now it has been prolonged here. This phase 2 is getting prolonged. So once the action potential is completed, this phase 4 is also prolonged by the sodium channel blocker. The suppression of action potential generation in the phase 4 is suppressed. So there is a period of inexcitability in between two action potentials. Then after a longer period, the second action potential occurs, and there also the slope of phase 0 will be suppressed and the total duration of action potential will be prolonged. So let's see each drug one by one. So quinidine was one of the first antiarrhythmic drugs. It was used to treat rebellious palpitation. So whenever the heart rate is increased to a higher rate, the patient feels as if the heart is thumping from inside. He can actually feel the sound and it's quite uncomfortable for the patient. That's called as palpitation. So severe form of palpitation is called rebellious palpitation. So quinidine has the ability to increase the threshold for excitability. So what I've shown in the previous diagrams, if you increase the threshold, a higher amount of stimulus is required to generate an action potential. And on the same side, it suppresses the automaticity of the SA node. So when the automaticity is suppressed, the duration of action potential will be prolonged. So these are mechanisms by which you can decrease the heart rate. Moving on to the pharmacokinetics of quinidine, it is well absorbed orally. It is 80% bound to plasma proteins. It is metabolized in the liver. So quinidine is used to maintain the sinus rhythm in patients with atrial flutter or atrial fibrillation, and also to prevent the recurrence of ventricular tachycardia or ventricular fibrillation. So just you can remember these two terms, flutter and fibrillation, used on both sides, in atria as well as ventricular. Atrial flutter, atrial fibrillation, ventricular flutter and ventricular fibrillation. The quinidine has a long list of side effects. Among the non-cardiac side effects, it causes diarrhea, thrombocytopenia, decrease in the platelet count. Synchronism is a very important side effect of quinidine. When you see in pharmacology, you'll hear about three isms. One of them is synchronism. So, a drug overdose of quinidine will result in tinnitus, headache, nausea, blood vision, and vertigo. And because of hypersensitive reaction, it can cause skin rashes. Among the cardiac side effects of quinidine, it can increase the QT interval in ECG. The distance between Q wave and TA will be increased because it is increasing the action potential duration. So that may lead to Torsades de Pointes. But Torsades de Pointes is a severe form of ventricular arrhythmia where you see a haphazard pattern in the ECG. Like some of the R waves will be pointing upwards, and then you will see a series of R waves pointing downwards, and again a series of R waves pointing upwards. So this in French, Torsades de Pointes means twisting of points. So you see the twisting of points on the ECG. Then cardiac quinidine will cause vasodilatation, so that may lead to hypotension, and because of hypotension, that may cause reflex tachycardia. The point to note here is that quinidine is given to control arrhythmia, but in abnormal dosage, if you not monitor the patient properly, that may lead to arrhythmia again. Again, plenty of drug interaction of quinidine. It increases the digoxin levels by displacing the other drugs from the plasma proteins, and also by inhibiting the channel P glycoprotein. So P glycoprotein is a channel located in the kidneys and also certain cells, whose mechanism is to cause removal of the certain ions or compounds from the cell from inside to outside. So by inhibiting the P glycoprotein, it may enhance the excretion of certain drugs. So digoxin is metabolized by cytochrome P450, the most common enzyme for metabolism of many drugs. You can see that drugs like cimetidine will inhibit the metabolism of quinidine, so the levels of quinidine will increase. The patient will suffer from QT prolongation, and likewise, combination of quinidine with rifampicin will lead to metabolic induction. So that will lead to decreased action of quinidine. The next drug in the class 1A is the diisopyramide. It exerts electrophysiological effects very similar to quinidine, but most of the side effects of quinidine are lessened in diisopyramide. But there are certain new unique side effects in diisopyramide. It causes precipitation of glaucoma and has certain anticholinergic side effects: constipation, dry mouth, and urinary retention. Procainamide is actually procaine is a local anesthetic. So you are adding amide to procaine to make it procainamide. It does not have potent sodium channel blocking activity, but it is still sufficient enough to control arrhythmia. Side effects: it may cause hypotension, Torsades de Pointes, and drug-induced lupus syndrome. It's a severe hypersensitive reaction. So that was all about the class 1A drug. Remember, they suppress the phase 4, phase 0 slope and prolong the action potential duration. Well, now moving on to the next class of drugs, the class 1B drugs. We have lidocaine or lignocaine, mexiletine, phenytoin, toconide. So as you can remember, lignocaine or lidocaine is the drug used in local anesthesia, and phenytoin is a anti-epileptic drug. Both of them act by the same mechanism. They inhibit the sodium channel. Specifically, they increase the duration of the inactive state of sodium channels. And the same mechanism you will see in the heart. So all these class 1B drugs, they block both the open state as well as the inactive state of the cardiac sodium channels. They shorten the action potential duration. In the previous class 1A, what you have seen as the action potential duration was prolonged, but here 1B is shortening the action potential duration. Selectively, they act on the diseased tissue and promote conduction block. Now the first part is similar to class 1A. The slope of phase 0 is suppressed, but the duration of action potential is shortened. Now you may ask me, like, if you are shortening the duration of action potential, how you are suppressing the heart rate? The thing is that the duration of the action potential duration, but the distance between two action potential will be prolonged. So that's how the heart rate will be suppressed. So lignocaine is a local anesthetic. It also used as antiarrhythmic. And the thing is that it is not so useful in atrial arrhythmia. We preferably use it for ventricular arrhythmias. Why? Because the state of depolarization, the duration of action potential in the atria is so short that it is not sufficient for lignocaine to act. So this is a comparison of the action potential in different parts of the heart. Like you can see in the atrium and the AV node, the action potential curve is very small, whereas in the myocardium endocardium, the duration is very long. So because in the atria the duration of action potential is very small, it is not sufficient for lignocaine to act. So that's why we use lignocaine only for the lower side, the ventricular tachyarrhythmias. So lignocaine has high first pass metabolism. It has a half-life of 1 to 2 hours. It has to be given in a loading dose followed by a maintenance dose. It's the agent of choice for the termination of ventricular tachycardia and can be used to prevent ventricular fibrillation after cardioversion. So by the way, cardioversion is that machine you see in the ICUs where there are two paddles, one is kept on the chest and second on the sternum, and then a fixed amount of current is passed onto the chest so as to stimulate the beating of the heart. That's called as cardioversion. The thing is, when you apply such a high amount of DC current onto the chest, the current can convert an asystolic heart to a ventricular fibrillation with high heart rate. So you can normalize the heart rate by giving lignocaine. Adverse effects of lignocaine causes tremors, dysarthria, means difficulty in talking, difficulty in the articulation of words. Lignocaine can cause seizures. It can alter the level of consciousness. Nystagmus is an early sign of lignocaine toxicity. Next drug in the 1B is mexiletine. It's a lignocaine analog. It has been modified to reduce the first pass metabolism. So we can use a less amount of dose. If we can use less amount of dose, naturally the side effects will also decrease. And also you can give the drug orally. Mexiletine causes tremors, blood vision, lethargy, and nausea. Next, coming to the class 1C drugs, anakinide, flecainide, propafenone, and morphine. So these are powerful inhibitors of sodium channel and they have less effect on the repolarization. So here also the same thing, the slope of phase 0 is suppressed. It blocks the sodium current and to a certain extent the potassium currents are also blocked. The flecainide, 1C drug, is used specifically for PSVD. PSVD stands for paroxysmal supraventricular tachycardia, including WPW. In the first class, in the classroom I told you, WPW is the Wolff-Parkinson-White syndrome where there is a development of accessory pathway between the ventricles and the atria. So there, the atria and ventricles, they will beat in the ratio of 2:1 or 4:1. Flecainide also used in life-threatening ventricular tachycardia. Now, one thing you understand that generally the atrial tachycardias are not so dangerous. They are long-standing, some complications can occur, but generally death will not occur. Whereas ventricular tachycardia, that always occurs in the acute phase. Once ventricular tachycardia occurs, it will be life-taking if you don't control it within few minutes. So generally VT is life-threatening, but atrial tachycardia will not be life-threatening. So we need a short-acting drug. So flecainide is most suitable for ventricular tachycardia. Side effects: flecainide causes dose-related blood vision, may exacerbate congestive heart failure. Now there are certain more complications of flecainide. It has been shown that flecainide causes pro-arrhythmic effects, just like quinidine. One thing you understand that most of the anti-arrhythmic drugs, they themselves will cause arrhythmia. At the end of this chapter, I tell you what are the drugs which can cause arrhythmia. They are called as arrhythmogenic drugs. So because of this, flecainide has the increased mortality rate. It has pro-arrhythmic effects, especially in the presence of structural heart disease. Means if there is any mitral valve prolapse or AV septal defect, in such cases, flecainide can cause arrhythmias. Propafenone is an analog of propranolol, a beta blocker. It is used in life-threatening ventricular arrhythmias and for suppression of any kind of supraventricular tachyarrhythmias. It is called as pill in the pocket. So those patients who are suffering from atrial fibrillations, they are told to keep a pill in their pocket. Whenever they feel some kind of palpitation, they can consume the pill. Totally contraindicated in asthma. And if you remember, we have seen in ANS, propranolol is contraindicated in bronchial asthma. Why? Because it's a beta blocker, non-selective, and antagonizing the beta 2 receptors will cause bronchoconstriction, so that will aggravate asthma. So propafenone, since it is a propranolol analog, will also cause asthma. So propafenone also has certain bad reputations. It has it can increase the mortality and increase cardiac arrest. So this is a comparison of all the three subclass of class 1A, 1A, 1B, 1C. So all the three classes will suppress the phase 0 of the action potential, but the degree of suppression is different. Like say 1C is most potent in blocking, it's suppressing, whereas blue color is 1B. 1B is very weak, and 1A lies in between. So that's why 1A is moderate, 1C is very strong. 1C is strong, 1A moderate, and 1B is very weak. And coming to the duration of action potential, as you can say, 1A will prolong the duration of action potential, but 1B is lying inside, so 1B will shorten the duration of action potential, whereas 1C will prolong the duration of action potential but to a minor extent. See, ERP is the effective refractory period, which is increased by 1A, decreased by 1B, and is almost same in the 1C. So this was all about the class 1 sodium channel blockers. Thank you.